Thank you, Nadal. Well, as we've already been discussing, atrial fibrillation is a huge risk for stroke. These are data we looked at earlier this morning. Clearly an issue for us. 15% of strokes are attributed to AF, especially in the elderly. We've seen these data before. We've talked earlier today about the CHAD score. Let me just quickly review that for those of you who are not familiar to it. So the CHAD score is a look at units that may contribute to the risk of stroke in patients who have atrial fibrillation, not just the risk of fibrillation itself. And so the CHAD score has been updated recently to the CHAD's VAS score, where for reasons that we'll get into, this helps to further stratify patients very nicely according to the risk of stroke by adding in components of vascular disease, gender, and then also giving more weight to patients who are really elderly over the age of 75, with 1 point for age 65 to 74 and 2 points for patients over the age of 75. So this gives you a maximum score potentially of 9. This seems to work quite well. In the current European guidelines, we see that the CHAD's VAS score, going from a score of 0, of low risk to high risk, correlates quite well, almost a linear response with the annual stroke rate. And this has been validated numerous times. The most important validation comes from a large cohort in Denmark, where they've got the entire population under surveillance, and they can look at the outcome of patients who have atrial fibrillation relative to their risk. And what they did was to look at those patients who had atrial fibrillation who were not receiving anticoagulants. So here are 73,000 individuals with atrial fibrillation not receiving anticoagulants. The CHAD score seems to work quite well, but even the low-risk individuals with a CHAD score of 0 still have an annual stroke rate or thromboembolic rate of 1.7. The CHAD's VASC score does a better job of discriminating the low-risk group. And so the low-risk group now has an annual stroke rate of 0.8. If you look at the numbers of individuals of these 73,000 patients within each bar, you see that the highest risk individuals on the right are very few in number relative to the others. And so when you do the look at the absolute risk, not the relative risk, where are all the strokes occurring, most of the strokes are occurring in the middle group. So clearly the groups to the far left remains low risk, but the groups even in the intermediate risk have great risk of stroke, and that's where most of the strokes occur. And so low risk now is defined as the CHAD's VAS score of 0, 0.78% risk per year. Intermediate is a CHAD score of 1, and anything more than 1 is considered high risk, where the cumulative risk is 8.82% per year. This also correlates with mortality because of the various comorbidities that add to the CHAD score, not just the risk of stroke. And so there's a very nice linear relationship with mortality from the CHAD's VAS score. So it's a very nice way of risk stratifying patients according to not only the risk of stroke, but also their risk of adverse outcome. And so interesting analyses have been done using this database. Here, for example, is looking at individuals who have a CHAD score of 0 in the heavy curve, or a CHAD score of 1 using the original CHAD score. And you can see the problems with the CHAD score of 1, because if it's hypertension, that has a different outcome than if it's just age alone on these individual plots. So all of these individuals in the 4 lower curves would be considered to have a CHAD score of 1, and you can see the outcome is much different depending upon the individual characteristic, which added that 1 point to the CHAD score. Whereas the CHAD's VAS score, by adding in these other variables, tightens up the group of patients who have the CHAD's VAS score of 1, because now each of these individual plots shows that the outcome is very, very similar with this particular scoring system. And another way of looking at this is a separate paper from the same database a year later, looking at individuals who have a CHAD score of 0 on the left and the various strata by implementing a CHADS VAS score instead. So that one finds that if you have a CHADS VAS score of 0 in the upper purple curve, the outcome is significantly better than if you have a CHADS VAS score of 3 in the blue curve at the bottom, even though the CHADS score would be 0. And even more importantly, on the right, if you have a CHADS score of 1, the CHADS VAS score is much better at more accurately pointing to the risk. That would be important because some patients with a CHADS score of 1 might have a CHADS VAS score of 4. So this is the data that are now being used, and you can see one more time how the CHADS VAS score in red it does a better job of identifying the low risk group, and even the intermediate risk group has a lower risk compared to the CHADS score. So the CHADS VAS score is the one that's now been recommended. It's been validated now in about 5 different studies, as you can see, over 153,000 patients. It's incorporated into the current ESC guidelines that the CHADS VAS score is recommended as a means of assessing stroke in patients with non-valvular atrial fibrillation. Now that has to be balanced against the risk of bleeding. And so one has to also consider what is the risk of bleeding with an antithrombotic agent. And here we can use several scoring systems. The one which is most often used is the HAS-BLED score, incorporating hypertension, abnormal renal or hepatic function, previous stroke, previous bleeding, label INRs with warfarin, elderly, and then drugs or alcohol. Maximum score again would be 9. And this clearly has been well validated as a scoring system because here are data from the same group in Denmark following patients over the course of 1 year on anticoagulation therapy, looking at their risk of bleeding. And the HAS-BLED score nicely stratifies this group. So one has to balance now the risk of stroke versus the risk of bleeding. And the risk of bleeding is also somewhat related to ethnicity. We talked earlier about how the risk of fibrillation and the risk of stroke might be related to ethnicity, but in the Asian population, at least in these data by Shen and co-workers, the hazard ratio for intracranial bleeding on warfarin is also much higher, 4-fold higher than the Caucasian population. Again, it would be very interesting to know what the data look like in Qatar or in this region relative to the rest of the world. And hopefully we'll get some data from the Gulf registry. Now, how about aspirin? If we have concerns about bleeding, perhaps we should use an agent, an antiplatelet agent, which would have lower risk. But the question is whether it's as effective. These are data, a meta-analysis by Hart and co-workers looking at trials of aspirin versus placebo in patients with atrial fibrillation, showing really not that much of a benefit when one does the look at all the data, but some of the individual trials clearly showed no benefit of aspirin. In comparison, warfarin clearly shows benefit. So warfarin is better than aspirin. The active W investigators looked at patients who were receiving either clopidogrel plus aspirin versus an oral anticoagulation agent, and demonstrated, as you might expect, that the oral anticoagulation therapy was more effective than adding clopidogrel to aspirin in terms of the primary endpoint of thrombosis. And if anything, the bleeding risk was not reduced with clopidogrel plus aspirin compared to the oral anticoagulation therapy. This was not significant, but if anything, the oral anticoagulant led to less major bleeding, and the risk of stroke was clearly greatly reduced by the oral anticoagulant. So this would suggest that if patients are candidates for oral anticoagulants, they should receive this and not aspirin. In patients who are intolerant of an oral anticoagulant for whatever reason, There are some data that adding clopidogrel to aspirin might lead to a significant benefit in terms of aspirin only. That's from the active investigators also in active A, published in the New England Journal of Medicine. However, one has to balance that particular potential benefit of adding aspirin, adding clopidogrel to aspirin in the light bars, where you have fewer vascular events and fewer strokes, but a higher risk of bleeding. And so the conclusion of this paper was in patients who are intolerant of oral anticoagulants, adding clopidogrel to aspirin might lead to a significant but slight reduction in the risk of stroke, but at the expense of an increase in bleeding. So again, individualizing therapy based upon these various risk considerations would be important. Finally, the Avros investigators looked at patients who could not tolerate a vitamin K antagonist. They could not tolerate warfarin. And they were randomized to receive either aspirin or the new anti-10A inhibitor, apixaban, which we'll talk about in a few minutes. And apixaban clearly was more effective than aspirin at reducing the risk of stroke or systemic embolization over the course of a year and a half, and also did so without a higher risk of bleeding. And so I think the bottom line on all of these data is that there's actually very little role for aspirin in stroke prevention in atrial fibrillation patients, especially those who have a CHADS VAS score greater than 0. Okay, so now we have guidelines. The US guidelines in 2006, the European guidelines in 2010, came back with the American guidelines in 2011, and then the European guidelines in 2012. They're all telling us that we should be using oral anticoagulants for our patients, and now we have the opportunity to consider some of the new agents. We're all aware of the limitations of warfarin. The slow onset of action leads to concerns when we're switching from parenteral to oral therapy. There's genetic variation in metabolism leading to variable dose requirements with multiple food and drug interactions. Our patients have to be very careful of ingesting vitamin K. Leads to the need for frequent coagulation monitoring. Narrow therapeutic window, risk of bleeding versus the risk of clotting, requiring, again, frequent coagulation monitoring. It's a major nuisance, and none of my patients like taking warfarin. And indeed, if you look at the accessibility of patients to warfarin, in patients who are eligible and should be receiving warfarin, we saw data from this earlier in the UK. Here are data from the US looking at the patients who receive warfarin independent of age. Only about 60% or less of patients who should be receiving warfarin are actually taking it. And those who are taking it often are not within the therapeutic range. The time in the therapeutic range is notoriously low. Maybe 50% of the time are patients actually who are taking warfarin actually in the therapeutic window. So there are major issues with the use of warfarin that we're all aware of. It is inexpensive. It is available. It does require frequent blood testing. So, without going through the entire coagulation cascade, we know that warfarin works on several levels of our vitamin K-dependent proteins. We now have direct thrombin inhibitors, and we also have direct factor 10A inhibitors. Let's talk about those now for the remainder of the presentation and see where they fit in. These are now available to me. I'm hearing that some of them are available to you, and others that we'll be talking about will soon be available to you if they're not available already. Okay, so they come in two varieties. You have dabigatran, which is a direct thrombin inhibitor, or rivaroxaban or apixaban, which are the direct 10A inhibitors. I was given a clue to this just last week, actually, and that is the direct 10A inhibitors have 10A in their name. Notice there's an XA in their name. That's how you can tell they're 10A inhibitors. Okay, so the mechanisms are clear. Bioavailability is much higher with the 10A inhibitors than with the dabigatran. You see other data regarding their time to peak, their half-life. Notice that the rivaroxaban, which is a once-a-day preparation, has a half-life. It's really no different than apixaban. Is there a pointer here, Jim?
Yeah, that's
Right. There, good. I have a pointer. Notice the half-life here, rivaroxaban versus apixaban. Pharmacologically very similar, yet this is marketed as a once-a-day preparation. This is twice a day. Renal excretion, very important because dose has to be modified if there is chronic kidney disease, as you can see here, lower doses. Special considerations, dabigatran has to be given with some concern in patients taking proton pump inhibitors. And one has to worry about the renal and hepatic disease issues in virtually all of these drugs, but in particular rivaroxaban, which has some hepatic excretion as well. Potential drug interactions are shown here. That has to be kept in mind for all of our patients. And then we have trials, randomized clinical trials in all three of these drugs that you're aware of. Rely, Rocket, AHF, and Aristotle, each one related to each of these three agents. The dabigatran study was open label versus the two 10A inhibitor trials, which were double blind. Large trials, thousands of patients, followed up for a year to a year and a half. Age is very similar. The CHADS-2 score was actually quite similar, maybe slightly higher with the Rocket AF study. High prevalence of diabetes, higher in Rocket AF. Previous strokes also higher in Rocket AF. So Rocket AF was a sicker population, as you can see, based upon their baseline characteristics in terms of the CHADS score and the comorbidities. At the bottom is the what we saw earlier about the difficulty in maintaining Coumadin. So when we talk about a drug being quote-unquote better than warfarin, it may or may not be better than warfarin if patients are actually maintained in the therapeutic range. But since patients are out of the therapeutic range so often, it's not surprising that a drug which is more constant may give better results. Okay, so let's talk about the Rely trial, which is the dabigatran versus warfarin. This was the first such agent. Gave the drug in two doses, dabigatran 110 milligrams versus 150 milligrams. The 150 milligram dose clearly led to a reduction in the cumulative hazard rate of stroke or systemic embolization. Regarding the bleeding issues, neither the higher dose of dabigatran, although more effective than warfarin in reducing strokes, was no better than warfarin regarding bleeding. The lower dose of dabigatran led to less bleeding. But both doses led to a significant reduction in the middle panel of severe intracranial hemorrhage. That was one of the important take-home messages from this trial, whereas the combination of major and minor bleeding was also significantly reduced by either dose. The rivaroxaban study, Rocket AF, also showed a significant reduction in the primary endpoint. Remember, a lot of patients taking warfarin in these trials were not within the therapeutic range, about 50% of the time with warfarin, which may explain the results. And again, there was a significant reduction in intracranial hemorrhage, even though there was no difference in the overall bleeding, either major or minor, but the middle panel was important because of the reduction in intracranial hemorrhage, i.e. Hemorrhagic stroke. And then finally, the Aristotle trial with apixaban showed a different characteristic of this particular agent, we believe, relative to the other trials. At least the results were different. Whether the drug itself leads to better outcomes in the real world is unclear. But in this trial, apixaban not only led to a reduction in stroke and systemic embolization, like the other two drugs, but also led to a significant reduction in major bleeding. So this has kind of captivated the U.S. clinical community that this might be a drug that has nice, favorable characteristics. So what do these studies tell us? That the likelihood of reduction in stroke and systemic embolization clearly reduced. The reduction in hemorrhagic stroke significantly reduced. Mortality may or may not be reduced. There's a trend actually toward reduction in mortality in all three of these trials, although none of them were significantly designed. They were not designed to do that, and these results were not significant. Perhaps longer term data from future trials might show a mortality benefit as well. So this is now incorporated into the current ESC guidelines. We'll see if the US guidelines also mirror this. If patients have valvular atrial fibrillation, they should receive a vitamin K antagonist, Warfarin. So these drugs are not yet approved for, the new drugs are not yet approved for the patients who have valvular atrial fibrillation, and in particular patients with mechanical heart valves. That trial was negative with dabigatran. If patients have are young and have lone atrial fibrillation, then perhaps no antithrombotic therapy might be an option. These might be the patients one would consider for aspirin. Or if the CHADS VAS score is 0, these low-risk patients, perhaps no therapy at all, maybe consider an antiplatelet drug. But if patients have a CHADS VAS score of 1 or greater, they should not receive aspirin. They should receive an oral anticoagulant therapy. And it was quite interesting. We saw earlier the data from the UK about all the patients who are receiving aspirin, especially the older individuals. And those are the patients at greatest risk, who have the highest benefit from the antithrombotic drugs. So hopefully there'll be a change in the reactions of the clinicians based upon guidelines like this and very strong data that aspirin is not effective. So the oral anticoagulant therapy should be considered, but consider also the risk of bleeding from the HAS-BLED score. And this then would lead one to consider either a novel oral anticoagulant or a vitamin K antagonist. So to conclude, AF and thrombotic risk is a major cause of stroke in the elderly. Stroke prevention is a major goal of treatment, no matter how else we're treating patients with rate control or rhythm control. Thromboembolic risk can be assessed using the CHADS VAS score, especially identifying the low-risk group more accurately, who may require no therapy at all. Anticoagulation is indicated for all patients except for those at very low risk. Aspirin has no value in stroke prevention, and oral anticoagulants are safe and effective, may improve compliance because of their ease of, from the patient's point of view, as well as from the clinicians. Thank you very much for your attention.